Hi, dear student. I am Dr. Haider Alidrisi, and this lecture represents the sixth lecture in the series of Diabetes Endocrinology, Department of Medicine, University of Basrah College of Medicine, and also the first lecture that will talk about the pituitary-related disorders and the diseases of the hypothalamus and pituitary actually have an annual incidence of approximately 3 per 100,000 with a prevalence of 30 to 70 per 100,000. Why the talking about pituitary gland is important? Because it represents the master endocrine gland in the body that have mastering role on other endocrine organs. And for this reason, the pituitary plays a central role in several major endocrine axes, and so that investigations and treatment invariably involve several other endocrine glands. And this lecture will talk about pituitary tumors and specifically the pituitary adenoma. And adenoma actually a histological term as the commonest type of pituitary tumors, while pituitary tumors actually present an abnormal neoplastic growth related to the pituitary or a cellular mass, which could involve the metastasis, malignancies, but most commonly a benign growth of the pituitary, specifically related to the anterior pituitary glands, which is called the pituitary adenoma. Importantly, to have some review about the pituitary gland anatomy, and the best way is to have a look by MRI image both by coronal and sagittal section of the pituitary. And here's by the coronal section, the pituitary gland enclosed in the cella torsica and bridged over by a fold of dura mater called diaphragm cilia, with the sphenoid sinuses below and the optic chiasm above. And here's the anterior pituitary glands, and here the internal carotid artery, and here the cavernous sinus. These two important structures, internal carotid artery, represent the major and the most important and abundant blood supply to the brain, and the cavernous sinus represent the venous drainage. But the important thing about the cavernous sinus actually, inside it contains the oculomotor nerve and trochlear nerve and the abducent nerve, and also the ophthalmic division of trigeminal nerve. So diseases that can affect pituitary gland can have an effect, an adverse effect on these two important structures. This part represents the pituitary sac that connect the hypothalamus to the pituitary gland to have an important role in controlling some of the function of the anterior pituitary glands. And here's the optic chiasm located just superiorly above the pituitary glands. So when there is lesions like tumors, especially if it is large enough, can result in compression of the optic chiasm from below. The important thing that optic chiasm contains the nasal part of the optic nerves crossing, and so compression of the optic chiasm from below can result in defect in the visual field of both eyes, resulting in bitemporal hemianopia. And here's the position of the third ventricle. In the sagittal section of the pituitary gland, we can see here the anterior pituitary glands, and here's this bright spot by this image present the neurohypophysis or the posterior pituitary gland. And here's the optic chiasm, here's the hypothalamus, and below its connection by the pituitary stalk, and here's the third ventricle, and here present the sphenoid sinuses. So when we have a look to the pituitary gland is in its position in the cella torsica, and it is in the central, just in the center of the brain. So any disease and any lesions, especially importantly tumors, if it is large enough, can result in compression of many of these vital structures. So disease of pituitary gland have a direct effect on pituitary function itself, and also can have an impact and adverse effect on the surrounding structures like the brain structures, including frontal lobe, temporal lobe, the cranial nerves in the cavernous sinuses, and the also compression of the optic nerve from below can result in compression of the third ventricle, or obstruction of the foramen of Monro above, resulting in obstructive heart. And now moving to the physiology of the pituitary endocrine functions, because understanding of the pituitary endocrine functions actually important to understand the clinical feature of different and variable pituitary disorders, and also in order to understand the laboratory investigations that have been used for evaluation of pituitary disorders. In this slide, I will summarize the pituitary function, and these are the important anterior pituitary hormones. Here the luteinizing and follicular stimulating hormone, which represent the gonadotrophin hormone and the thyrotrophin stimulating hormone, prolactin and the growth hormone, and the ACTH, the adrenocorticotropic hormones. These five hormones, all these hormones secreted from the anterior pituitary glands, while the arginine, vasopressin, and the oxytocins, these released from the posterior pituitary gland or neurohypophysis. Actually, the luteinizing hormone and the follicular stimulating hormone, these released from the anterior pituitary gland by the effect of the impulses from the hypothalamus of the gonadotrophin releasing hormone, the GnRH. These GnRH pulses stimulate the pituitary gland to release the gonadotrophin, and so the LH and FSH will stimulate the testes in the male and the ovaries in the female in order to release the estrogen and progesterone in female, and the androgen, the testosterone, by the testes. And these hormones represent their function and their role for the reproductions and the sexual functions and sexual characteristics, specifically for both genders, male and female. And also at the same time, the estrogen and progesterone and androgen, beside the prolactin and inhibin, represent the regulatory hormones that can inhibit the GnRH pulses. So there's a stimulatory effect, and also there's controlling and regulatory effect above the hypothalamus. The prolactin that released from anterior pituitary gland inhibited by the dopamine release from the hypothalamus. So there is persistent inhibitory effect for the prolactin release by dopamine. But the prolactin release will stimulate the breast, and the breast will be stimulated to produce milk for the process of lactations. Beside the inhibitory effect on the prolactin release by the dopamine, estrogen and stressful conditions can stimulate the prolactin release. And let's move to the thyroid functions, and the TSH actually is stimulated to be released from pituitary gland by the TRH, thyrotrophin releasing hormones. The TSH responsible for stimulating the thyroid gland to release both T4 and T3, and these T4 and T3 hormones responsible for metabolisms. And actually we talk about these hormones and their functions specifically when I'm going to talk about the thyroid disorders. T3, actually the regulatory hormones that are responsible for the feedback inhibitions that have an inhibitory effect on the hypothalamus to suppress the release of TRH and so TSH. Let's move to the growth hormone. The growth hormone actually is stimulated by growth hormone releasing hormone from the hypothalamus, and also at the same time the somatostatin have an inhibitory effect on the growth hormone release. The growth hormone by itself is not active. Growth hormone will act on the liver to stimulate the release of IGF-1 and IGF-1 binding protein, the insulin-like growth factor 1 and insulin-like growth factor 1 binding proteins, and these, the IGF-1 responsible for the growth functions and for the linear growth, responsible for the final length and stature of the human beings before the closure of the epiphysis, and the IGF-1 actually responsible for the negative feedback inhibition on the GRH release from the hypothalamus. Let's move to the adrenal functions. The adrenocorticotropic hormone released from the anterior pituitary gland by a stimulatory effect of the CRH, which is the corticotrophin releasing hormone. The ACTH by itself will stimulate the adrenal cortex to release the cortisol and androgen. And this androgen represented by the HEAS, the dihydroepiandrosterone sulfate, and the cortisol responsible. Actually, I believe this is the most important hormone from the pituitary and the adrenal functions, responsible for responsible for coping the body against stress, and also have an important role for the body metabolism. And cortisol by itself have a negative feedback inhibition on the CRH released from the hypothalamus, and all that regulated by circadian rhythm. So there will be a circadian rhythm. The day to night cycle can control the release of CRH from the hypothalamus. So there will be a variability and dynamicity in the cortisol and the CRH and ACTH level according to different parts of the day. Increase in osmolarity of the intravascular volume. So increasing the serum osmolarity will stimulate the vasopressin release from the neurohypophysis and posterior pituitary glands. And so this vasopressin actually stimulates both the ACTH release from the adrenal cortex and also stimulate the distal nephron from the kidney to maintain water balance, increase the free water reabsorption, and reduce the free water excretion of the kidney in order to counteract the increase in the intravascular osmolarity. And finally, the oxytocin have a stimulative effect on both the breast and uterus. And so stimulation of the uterus by the oxytocin responsible for labor and parturition and for contraction of the uterus. And the oxytocin stimulate the process of lactation. Oxytocin stimulate the release of the milk that's already developed by the function of the prolactin. This slide shows the major classification of diseases of pituitary and the hypothalamus, and can be classified as functioning tumors, hormonal excess disease or hormonal deficiency disease, or hormone resistance. And pituitary adenoma itself represent the commonest pituitary tumor and also present the commonest pituitary disorders. And either it is a secretory, result in hormonal excess, or non-secretory, represent an unfunctioning pituitary adenoma. And also we have another non-pituitary related tumors like craniopharyngioma, and sometimes rarely we can found metastatic tumor can affect the pituitary and especially affect the posterior pituitary gland, or what is called the neurohypophysis. And for this reason, the metastatic tumors usually have presentations different from presentation of disease that can affect the anterior pituitary gland. Metastatic tumor usually presented with a cranial diabetes insipidus. Hormonal excess result from a prolactin secreting adenoma affecting the anterior pituitary gland called the prolactinoma, or growth hormone secreting tumor resulting in acromegaly, or ACTH secreting adenoma resulting in Cushing disease, and rarely a TSH-OMA resulting in secondary thyrotoxicosis, and LH and FSH secreting adenoma, which is considered as a non-functioning pituitary adenoma. Hormonal excess from disease can affect the hypothalamus and posterior pituitary, result in syndrome of inappropriate ADH secretion, and if there is an excess in the release of antidiuretic hormone or vasopressin from posterior pituitary gland, result in reduction in the tonicity of the blood, resulting in reduction in the plasma osmolarity and hyponatremia. So there will be hypotonic hyponatremia. Actually, this is not a result of tumors of pituitary gland. Commonly, it's a result from a brain injury or a brain inflammation or meningitis or pulmonary diseases, usually secondary to other diseases. Now moving to hormone deficiency. Hormone deficiency is related to anterior pituitary, defined as hyperpituitarism. And hyperpituitarism, it's either panhypopituitarism, in which there is a deficiency of the whole different 5 hormones of the anterior pituitary gland, including the growth hormone and the ACTH and the prolactin and the TSH and the gonadotrophin. But sometimes the deficiency in the hormones, there will be an isolated deficiency in different hormones from the anterior pituitary gland. So when there is deficiency of the gonadotrophin of the FSH and LH, there will be secondary hypogonadism of the male and female, while the deficiency of the TSH resulting in secondary hypothyroidism, while a deficiency of the ACTH resulting in secondary adrenal insufficiency, and deficiency or reduction in the secretion of growth hormone from the anterior pituitary gland resulting in a growth hormone deficiency. And this is growth hormone deficiency. Its clinical significance may be important in the childhood and prepubertal, resulting in short stature. While hormone deficiencies from the hypothalamus or the posterior pituitary part result in reduction of the secretion of the ADH hormone, and so there will be diabetes insipidus, and called cranial diabetes insipidus because the central diabetes insipidus. And in this condition, we can see here there will be an increase in the serum sodium, an increase in the plasma osmolarity, and there will be increased urination and increased thirst feeling with the secretion of diluted urine. Secondary hormonal resistance actually it's actually rarely presented in a form of growth hormone resistance called Laron dwarfism or Laron syndrome, and it's a condition rarely inherited. It's ordered when there is a resistance to the growth hormone function at the level of liver, so there will be an IGF deficiency and resulting in a familial short stature, or resistance to the function or the action of the antidiabetic hormone at the level of the kidneys, resulting in peripheral or nephrogenic diabetes insipidus, which has a similar manifestation of cranial diabetes insipidus, but with normal or even high antidiabetic hormone. And this condition resulted from tubular disease that can affect the kidneys, many other causes, like a chronic tubular interstitial nephritis can result in nephrogenic diabetes insipidus. And also at the same time, beside the primary disorders that can affect the primary disorders related to the pituitary, we can have a secondary when there is lesions or a tumor result in disconnection or loss of the stalk effect, stalk function on the anterior pituitary hormone. There will be a loss of the inhibitory effect on the dopamine on the prolactin release, so there will be what is called disconnection hyperprolactinemia, and commonly seen in patients with big pituitary tumors. And other secondary disorders, which is an isolated GnRH deficiency, gonadotrophin-releasing hormone deficiency. It's inherited disorders, X-linked inherited disorder called Kalman syndrome. The GnRH deficiency from the hypothalamus resulting in reduction in the release on the FSH and LH, the gonadotrophin from pituitary, so there will be secondary hypergonadism manifested in early state as delayed puberty in male in tall statures, and also at the same time about a considerable proportion of those patients also have an additive features in the form of reduce the sense of the smell, so there will be anosmia, tall stature, and delayed puberty and hypogonadism. This table represents the major and most important classifications, a classification of the pituitary and the hypothalamus disorders. Now we'll move to talk about pituitary tumors, and specifically about pituitary adenoma, which is the commonest type of pituitary tumors. While pituitary tumor is a major term representing an abnormal, as I said previously, an abnormal neoplastic growth could be a benign tumor like meningioma or metastatic tumors, but it's most commonly a benign adenoma related to the anterior pituitary gland, and it's seen in 10 to 15% of all intracranial neoplasm, but its frequency is higher in autopsy series, can reach to up to 27%. And this increase in autopsy series related to the considerable higher proportion of pituitary adenoma that incidentally present without any symptoms. But what is the major manifestation of the pituitary adenoma, which is selectively usually seen in the anterior pituitary gland? The symptoms related either to hormonal excess when it is functionally secreting, like prolactinoma or acromegaly or Cushing disease, or if it is large enough to cause compression of the surrounding structures surrounding the pituitary glands, like compression of the optic chiasm above, result in a bitemporal hemianopia, or compression of the hypothalamus, or compression of the pituitary stalk resulting in disconnection hyperprolactinemia, or even sometimes invasion or encasement of the cavernous sinus can result in an adverse effect on the cranial nerves that pass through the cavernous sinus, like trochlear nerve and oculomotor nerve or abducent nerve. And the pressure effect or impingement effect of the pituitary adenoma, also if it is large enough, can affect the various function of the anterior pituitary gland, resulting in hypopituitarism, or even sometimes 2 or 3 or all other hormonal deficiencies of the anterior pituitary glands. And actually it is more helpful to have a classification on the pituitary adenoma in order to understand the different manifestation of the pituitary adenoma, and the classification of pituitary adenoma according to the function and according to the diameter. And so the pituitary adenoma classified according to diameter. If its diameter less than 10 millimeter or less than 1 centimeter is considered a microadenoma, and this actually rarely manifested, only if it is secrete hormone like microprolactinoma. So this small adenoma have no clinical functions unless it secrete hormones to have secretory function, to have manifestations like Cushing disease or hyperprolactinemia. Or macroadenoma, it is more than 10 millimeter or even larger, and this have a combination of manifestation. If it is secretory, it will have a hormonal excess manifestation, or if it is non-secretory, if it is large enough, can have a mass effect result in hypopituitarism or headache or visual field loss, like bitemporal hemianopia. And when we are going to do classification according to a function, it can be classified as either a functional pituitary adenoma or secretory adenoma that produce prolactin, resulting in hyperprolactinemia, or secrete growth hormones at an acromegaly or acetaceal Cushing disease. Or if this non-secretory microadenoma are common incidental radiographical finding and seen approximately 10% of normal population, and usually these adenomas do not require therapy unless they secrete or if they are large enough. While if this non-secretory tumors, if it is macroadenoma more than 2 centimeter, more than 3 centimeter, in this situation these tumors have mass effects, mass effect from the effect of this larger tumor on the surrounding structures, or directly on the anterior pituitary function, resulting in hypopituitarism. And this at this moment it will have a manifestation and require investigation and treatment. And so to summarize the classification, according to diameter, we have if it is less than 1 centimeter, it is microadenoma, and usually not presented unless secretory. And if it is more than 10 millimeter, it is macroadenoma, and will have a combination of manifestation, either a manifestation of hormonal excess or manifestation of mass effect. According to function, we have secretory adenoma that have a hormonal excess manifestations, or non-secretory adenoma, and usually asymptomatic unless if it is large enough to have a mass effect. And so pituitary adenoma can be either NFPA, clinically non-functioning pituitary adenoma, seen in 30% of pituitary adenoma, or prolactin secreting adenoma, result in prolactinoma in 35%, a growth hormone secreting result in acromegaly or gigantism, and combination of prolactin or growth hormone secreting adenoma secreting both prolactin and growth hormone, and ACTH secreting adenoma resulting in Cushing disease, and finally very rarely a TSH secreting adenoma called TSHoma, usually seen in less than 1% of the pituitary adenoma. And let's have also a summary of clinical feature of pituitary adenoma. And this clinical feature can be either due to pressure symptoms of the pituitary adenoma, like compression of the optic chiasm resulting in bitemporal hemianopia, or compression on various structures surrounding the pituitary, or clinical features related to hormonal excess like hyperprolactinemia or acromegaly or Cushing disease, and also we have hyperpituitarism, from the mass effect of the pituitary and the pressure effect of the pituitary adenoma on the pituitary gland itself. Let's start talking about a different special type of pituitary adenoma, starting by discussing prolactinoma, which represent the commonest secretory pituitary adenoma and hyperprolactinemia. And prolactinoma actually responsible for 20% of unexplained primary or secondary amenorrhea in women. So it's commonly presented in women and at early presentation. And for this reason, the presentation vary by gender. And for that, we can see that prolactinoma can present usually as microadenoma in female due to earlier presentation in female from its manifestations, while in male gender there will be a late manifestation, and usually you can see a macroadenoma as a cause of hyperprolactinemia in male gender. And also the variability in the presentation that vary according to the adenoma or the tumor size, also due to the fact that the level of prolactinoma or the level of the prolactin hormones that is secreted from the adenoma is strongly correlated with the size of the pituitary adenoma. With increasing size, there will be seen a higher level of prolactin. Besides that, larger prolactinoma, more than 2 cm, more than 3 cm, even more than 4 cm, which is defined as giant prolactinoma or giant microprolactinoma, have manifestation of the secretory function of this adenoma due to hyperprolactinemia, and also at the same time manifestation related to the big size of this adenoma, like a pressure effect on the surrounding structures. And so we'll start discussing the clinical features of hyperprolactinemia or prolactinoma among different genders, starting with female. Galactoria actually defined as the inappropriate expression of milk. The process of lactation, which is the physiological expression of milk from the female breast, while galactoria actually is an inappropriate lactation in the absence of pregnancy or the absence of the postpartum state due to non-physiological augmentation of prolactin release that will stimulate the mammary gland to produce milk, resulting in galactoria. And actually this galactoria can present both in female and male, but more likely will be seen in the female gender. Second, there will be also amenorrhea, or to less degree oligomenorrhea with anovulation. Anovulation means there will be a non-ovulatory cycle, and this usually associated with oligomenorrhea, and also this complicated by also infertility. This clinical feature in female population is the result that a prolactin release have an inhibitory effect on the GnRH release from the hypothalamus. So there will be suppression of the adrenal axis in a way that results in secondary hypogonadism in female, resulting in amenorrhea, whether primary or secondary, oligomenorrhea and ovulation, and final result in infertility. And so there will be a hypoestrogenic state, and this estrogen deficiency is due to mismatch between the estrogen level and the androgen level in female, resulting in hirsutism, but also at the same time the hirsutism is a result of the augmentation of the adrenal androgen release as defined by the hydroepiandrosterone sulfate, and this will be discussed later on when going to talk about the adrenal gland disorders. And due to also estrogen deficiency, there will be reduction in the vaginal lubrications. And estrogen hormone, besides its important effect or important physiological effect on female sexual characteristics and sexual functions, play an important role for maintaining the bone strength. And so when there will be an estrogen deficiency, there will be osteopenia and osteoporosis and increased risk of fractures. While clinical features of hyperprolactinemia or prolactinoma in male, as a result of later presentation of the prolactinoma, usually those males have a larger tumors, more common as a result of delayed diagnosis. So usually we see larger tumors in form of macroprolactinoma. Due to hypogonadism, also due to the negative feedback effect of prolactin on the gonadal axis, they will be defined by as erectile dysfunctions, reduction of the libido, and due to secondary hypergonadism. And also this also associated with infertility. Galactoria, as I said previously, it is rare because male lack the estrogen-dependent breast growth and differentiation, but we can see and can find galactoria as a presentation of hyperprolactinemia or prolactinoma in the male gender. Now going to discuss the causes of prolactinemia, as prolactinoma is not the only cause for hyperprolactinemia, so there are actually plenty of causes of hyperprolactinemia. So some of these causes are physiological. A physiological increase in prolactin level. Stress, actually an important stimulatory effect of prolactin release from the anterior pituitary gland, but it will be a minimal and trivial increase in the prolactin level. For example, feeding from needle and vein puncture or any stressful condition can result in some increase in the prolactin level. While pregnancy is the commonest cause actually of hyperprolactinemia, together with lactations. Pregnancy due to hyperestrogenic state that stimulate the prolactin release from the anterior pituitary gland, while lactations, the process of lactations by itself stimulate high increase in the prolactin level in order to augment the physiological appropriate process for lactation that required for nursing. Repeated breast examination by itself stimulate the mammary gland to give a stimulation for the pituitary gland to release prolactin. Pharmacological causes, actually, there are also drugs that can result, many drugs. Importantly, these three classes of medications, and as we discussed previously, the continuous inhibitory effects and regulatory effect of the dopamine release from the hypothalamus on the anterior pituitary gland to regulate the prolactin release. So interruption or defective in the dopamine function at the level of the hypothalamus is due to dopamine antagonists, for example, with the use of antiemetics like metoclopramide, domperidone, prochlorperazines, and also the antipsychotics like phenothiazine, uh, chlorpromazine, and thioridazine. These drugs, as a result of their antagonist effect on dopamine, there will be loss of the inhibitory effect of dopamine on the anterior pituitary gland, so there will be hyperprolactinemia. The same thing when considering talking about the dopamine depleting drugs like methyl-dopa or reserpine. Estrogen, in form of oral contraceptive pills, estrogen by itself stimulates the anterior pituitary gland to release more prolactin. And now moving to the pathological causes of hyperprolactinemia, there are actually plenty and long list, but the commonest is the microprolactinoma, prolactinoma itself, and 90% of them presented as microadenoma. Primary hypothyroidism. If you remember when we discussed previously the physiology of the pituitary gland, hypothyroidism, primary hypothyroidism as a result of the reduction in the release of thyroxine T4 from the thyroid gland, there will be an increase in the TRH at the level of the hypothalamus and TSH. And this TRH, as a response to primary hypothyroidism, this increase in TRH stimulates not only the pituitary gland to release more TSH, but also have a stimulation to the prolactin releasing cells. So there will be also an increase in the prolactin level in state of untreated severe primary hypothyroidism. Other pituitary tumors like non-functioning pituitary tumors, these tumors, they are large enough to cause compression of the pituitary stalk, result in disconnection hyperprolactinemia, and to also loss of the inhibitory effect of dopamine on the prolactin releasing cells. Sometimes growth hormone secreting adenoma co-secrete prolactin, and this has been found in 30% of people with acromegaly. Polycystic ovary syndrome is actually also associated with hyperprolactinemia, rarely hypothalamic lesions. Also, hyperprolactinemia has been found in patients with chronic liver or renal disease. Chest wall stimulation, just like a breast examination, chest wall stimulation like post-herpes zoster also stimulate hyperprolactinemia. Also, we can see when you are considering the differential diagnosis of patient presenting to hyperprolactinemia, you have to look for the east physiological causes, especially important, the pregnancy itself, different and long list of pathological causes, and the drug effect before going through extensive and exhausting laboratory evaluation for those patients. But we have to take into consideration the most common pathological cause for hyperprolactinemia is the prolactinoma. And so how to investigate for patients suspected to have hyperprolactinemia, for example, female patient presented with galactorrhea, amenorrhea, infertility. The first investigation start by exclusion of pregnancy by doing simply a pregnancy test and exclusion of renal failure, and also exclusions by history of the offending drugs that may be responsible for the hyperprolactinemia. After that, by simply measurement of basal prolactin level. This should be measured in the fasting state in the early morning, importantly. And so the higher increase in the prolactin level will be more correlated with the presence of prolactinoma, and more high and higher increase in the prolactin level correlated with the size of the pituitary of the prolactinoma. And so if the level of prolactin more than 200 nanogram per ml, it's actually diagnostic for the presence of prolactinoma, while basal prolactin level less than 20 nanogram per ml usually considered normal, and sometimes we can have an equivocal result, a level between 100 to 200 nanogram per ml considered being equivocal, but commonly we can see patient with prolactinoma having a prolactin level between 100 and 20 nanogram per ml. After confirming the presence of the hyperprolactinemia, we have to look for the cause, and nearly most of these causes and the commonest pathological cause for hyperprolactinemia is the prolactinoma. So we have to look for the source, looking and searching for the presence of these prolactinoma by doing a pituitary MRI as an imaging modality of choice. And here we can see two coronal pituitary image of two different patients presented with galactorrhea and amenorrhea. On the left of this slide, we can see here the arrow showing the presence of a small microadenoma, and the prolactin level was 150 nanogram per ml. And this prolactin level, this MRI image, actually diagnostic for the presence of the microprolactinoma. On the right, we can see here there is actually a larger prolactinoma, more than 2 centimeters, suggesting presence of the microadenoma, and the prolactin level of this female patient with a presentation of galactorrhea and amenorrhea 700 nanogram per ml. These two findings suggesting that the highest increase in prolactin level more correlated with the size of the prolactinoma. Now talk about the treatment of the prolactinoma. Dopamine agonist is the medical therapy of choice, and also medical therapy is the best, the first line and the best and the most effective and curative treatment of the pituitary adenoma secreting prolactin, even if it is large enough. Dopamine agonist in the form of cabergoline or bromocriptine, typically followed by a rapid fall in the serum prolactin even within hours, and also associated with a tumor shrinkage. These drugs, dopamine agonists, will have an inhibitory effect on these prolactin secreting cells, resulting in reduction of the prolactin level and also shrink the tumor, even can result in remission and resolution of the prolactinoma, especially in patients with microprolactinoma. And sometimes, very rarely, we can see that some of those patients have a prolactinoma that is resistant to treatment or fail to respond to treatment. In that situation, we have to do surgery for resection of this prolactinoma, and the surgical approach of choice is the transsphenoidal resection of the adenoma. A transnasal approach is the surgical modality of choice for the treatment of this condition, and also for resection of all pituitary tumors. The third modality is the stereotactic radiosurgery or gamma knife. It's actually also rarely needed, and sometimes needed if the patient failed after surgery, if there's a failure of response to surgery, there's persistent hyperprolactinemia after surgery, or the recurrence of the tumor after surgery, we can do gamma knife of stereotactic radiosurgery. But remember that the first line and the most effective and successful and curative treatment for prolactinoma is the medical therapy as defined by dopamine agonists in form of cabergoline and bromocriptine. Another type of secretory pituitary adenoma is the growth hormone secreting pituitary adenoma, and the resultant disease was called the acromegaly. It's actually a rare disease with the incidence that is 3 to 4 new cases per 1 million person annually, with a prevalence that reached to 60 cases per 1 million. There is, from an epidemiological point of view, there is no sexual preponderance, and the mean age of diagnosis nearly the same between male and female, 40 years in male and 45 years in female. Prolactinoma actually commonly presented as microadenoma, as I said previously, while here in acromegaly, the growth hormone secreting pituitary adenoma usually in 70% of patients have macroadenoma at the time of presentations. That may be even a larger microadenoma. And this is due to delayed diagnosis, as that the manifestation of the excess growth hormone release from this adenoma usually starts 7 to 8 years before the time of diagnosis certain. So the diagnosis usually late by a lag of 7 or 8 or even 10 years from the onset of growth hormone secreting pituitary adenoma started at the site of the pituitary. What is the pathophysiology of the disease of the acromegaly? When there is excess release of the growth hormone, the autonomous non-inhibited growth hormone release from the growth hormone secreting adenoma, this growth hormone will stimulate the liver to secrete more insulin-like growth factor 1 and insulin-like growth factor 1 binding protein. And this, the IGF-1, with over time, there will be excessive exposure of the peripheral tissues and the somatic tissues to this IGF-1, result in excessive growth of these tissues in different parts of the body, resulting in different manifestations that we'll discuss later on. But to discriminate two different type of diseases that result from the growth is actually not different diseases, related diseases. The gigantism, which starts if the presentation of the growth hormone secreting pituitary adenoma start before the time of the epiphyseal closure in the childhood age. At this time there will be the presentation of gigantism. While if the presentation, which is the usual and the common presentation, that the growth hormone secreting adenoma develop later on after the closure of the epiphysis of the bone, result in the commonest presentation of the GH secreting adenoma, which is the acromegaly. And this cartoon shows and this picture shows the different manifestations of the acromegaly due to growth hormone secreting adenoma. And you can see here, as a result of the tumor itself in the pituitary and due to changes in the bone structure of the brain, there will be headache. And also, as a result of excessive somatic tissue growth, there will be enlargement of the lips, enlargement of the nose, enlargement of the tongue, and also at the same time those patients have hypertension, and as a result of the excessive growth hormone there will be also impaired glucose tolerance and diabetes. So there will be hypertension and diabetes, And also there will be enlargement of the heart with the ventricular hypertrophy or cardiomyopathy. And the cardiovascular disease is the commonest and leading cause of death for those patients. Enlargement of the hands and the coarsening of the hands result in the carpal tunnel syndrome, and also effect on the musculoskeletal system result in the osteoarthritis that's usually irreversible even after treatment. Enlargement of the jaw result in what's called prognathism, and there will be a prominence of the supraorbital ridges in the face result in large frontal sinuses, and many other manifestations that affect the skin, like increased sweating, thickening of the skin, and enlargement of the feet. Commonly, those patients have a presentation of changing and increasing in the size of the shoe wears. One of the commonest manifestation, myopathy. So there's a wide spectrum of clinical manifestation, and also some of these manifestation may be the result of the tumor compressing the optic chiasm, resulting by temporal hemianopia. And also at the same time, those patients, as a result of the anabolic and the growthing effect of this excess growth hormone released from pituitary adenoma, those patients liable at high risk for development of colon cancer. For this reason, those patients should be considered for surveillance for the presence of colon cancer by the scheduling them for periodic colonoscopic examination. What if the acromegaly left untreated? There will be an increase in the mortality rate, and primarily from cardiovascular and respiratory causes, or combination of both. Death in 50% of untreated patients by age 50 years. So those patients will die at a relatively younger age than the expected age. And also there will be increased prevalence of colon cancer and other malignancies. How to investigate for the acromegaly? So if patients have these features that I discussed recently, these features was called the acromegaly or acromegaloidism. The investigation starts with the hormonal analysis. Measurement of serum insulin-like growth factor 1. Actually, this is a useful indicator of the growth hormone hypersecretions will be increased in patient acromegaly. And an important thing and the beneficial effect of measurement of the insulin-like growth factor 1 is that this hormone will not fluctuate throughout the day, while the growth hormone have fluctuating effects. So there will be difficulty in measurement of random growth hormone for assessment of acromegaly. So it may be useful as a simple screening test for the presence of uh, excessive growth hormone release. And as I said, as a result of the fluctuating effect and variability in the growth hormone level, we cannot measure or cannot diagnose the growth hormone excess or acromegaly by simply measurement of random or even fasting morning growth hormone level. So we have to do dynamic test in this situation. The dynamic test involve a growth hormone suppression test by measurement of the growth hormone after 75 oral glucose tolerance test, and this will be done after an overnight fast. Later on in the early morning, measurement of the growth hormone, the fasting state, and after intaking of 75 gram of glucose. The failure of suppression of the serum growth hormone below 1 nanogram per mol considered positive for the presence of the acromegaly due to growth hormone secreting pituitary adenoma. Moreover, we have to consider many other certain factors that can affect these analysis, the presence of cirrhosis, starvation, anxiety, type 1 diabetes, acute illness. These conditions may be associated with the growth hormone hypersecretion, so you have to take these factors into considerations. But generally, to summarize that, the best screening test by serum IGF-1 and also by doing a growth hormone under oral glucose tolerance test if the growth hormone fail to suppress below 1 nanogram per mole, this is considered diagnostic for the presence of acromegaly. And after confirmation of the presence of a growth hormone success by this hormonal analysis, the next step will be doing pituitary MRI as the imaging modality of choice to locate the presence of the adenoma. The treatment of choice of acromegaly actually, here's the story different from prolactinoma. The surgery is the treatment of choice for the acromegaly and the growth hormone secreting adenoma, and this is done by a transphenodal resection of the adenoma. If the surgery failed or the disease still persisted after surgery, we can use medical therapy in form of long-acting octreotide or non-secretory. And if you remember when we talked previously about the physiology of the pituitary hormonal effects, we said that the somatostatin have an inhibitory effect on growth hormone release from anterior pituitary gland, and for this reason, this long-acting octreotide giving 1 monthly shows in patients who have not responded to surgical therapy, but also have beneficial effect as the sole therapy for those patients sometimes if the surgery is contraindicated, and also if the patient waiting for the effect of radiotherapy to begin if the radiotherapy is the treatment modality of choice for those patients. And also sometimes medical therapy used as the neoadjuvant treatment to be added on surgery a few months before before doing the transphenol surgery. Patient may be given 3 shots, 1 shot every month to aid in the preoperative shrinkage of the tumor and so make the surgery more easy and softening of the adenoma. But still, the medical therapy will not cure the disease, and it's not a treatment modality of choice, but a second-line treatment. The first-line treatment is the transplant of the surgery. And also we have another option, which is the stereotactic radiosurgery or gamma knife. And this indicated in case of tumor recurrence after surgery, of the tumor persistent after surgery, or patient resistance to or intolerance to medical treatment if patient was on medical therapy. So we have 3 modalities of treatment. Treatment of choice is the transplant of surgery, and sometimes we can use medical therapy with surgery, or if a surgery failed or surgery contraindicated. And we have another choice of treatment, which is the gamma knife or the stereotactic radiosurgery. The surgical approach and the stereotactic radiosurgery, both of them have complications we have to consider, and these major complications, destruction of the pituitary gland function result in hyperpituitarism, and this can happen in up to 50% of patients, and this is more likely in patients who had surgery together with stereotactic radiosurgery. Ending with the final subject of this lecture is the non-secretory pituitary adenoma or clinically non-functioning pituitary adenoma. From its name, it is a non-functioning, so the presentation of this tumor is not from an excess like prolactinoma or the growth hormone secreting adenoma as acromegaly or Cushing disease or hyperthyroidism or else. The main presentation of these tumors either asymptomatic, discovered incidentally, and usually at this time it is small in size and sometimes large in size. So it is either incidentaloma or if this tumor large enough to have presentations. So at time of diagnosis, these tumors become large at the time of diagnosis, and the main manifestation due to the pressure effect. So the clinical features of non-functioning pituitary adenoma simply due to the pressure effect of these tumors, compression of the optic chiasm from below resulting in bitemporal hemianopia, and hyperpituitarism from the pressuring effect of on the pituitary secretory cells, and resulting in either panhypopituitarism or can result simply in hypogonadism in men and premenopausal women. If the tumor large enough to can cause the compression on the cranial nerves in the cavernous sinus, resulting in a cranial nerve deficit or cranial nerve palsies. Sometimes the tumor large enough to compress on the third ventricle, resulting in obstruction of the foramen of Monro from behind, from below. Sorry, this will result in obstructed hydrocephalus, and very rarely in the presence of very large pituitary non-functioning pituitary adenoma. The pressuring effect can reach to the hypothalamus and can affect the neurohypophysis. In a way, can result in diabetes insipidus. The treatment of choice of non-functioning pituitary adenoma is the surgical approach, the transphenodal resection of the adenoma, and the interesting here, the risk of recurrence is actually quite high in the presence of non-functioning pituitary adenoma. There will be a high recurrence rate, and for this reason, usually we need an adjuvant therapy. So we have to do surgery in form of transphenodal surgery, transphenodal resection of the adenoma. If there should be followed by surveillance. If there is recurrence of the tumor, the next step either to do a surgery or stereotactic radiosurgery, which is reserved for patients who have not responded to surgical treatment or still have symptoms from the adenoma. And so this is the end. Thank you for your listening. The next lecture will be talking about hypopituitarism and diabetes insipidus. And have a nice day.